Great. Welcome, everyone. I'd like to also send along my welcome to the Patient Safety Awareness Week webinar. This is our webinar 2. Had a great webinar yesterday around the safety of AI in healthcare. I'll be your moderator again for today's webinar. Just a little bit of background about Sinensis for those that weren't here yesterday. Our mission at Sinensis is to maximize the capacity of high-risk organizations like healthcare systems to achieve safer outcomes. Today's session is titled A Human-Centered Design Approach to Barcode Medication Administration, or BCMA, Alert, Message, Evaluation, and Redesign. This is a critically important topic. I know many of us understand the challenges associated with using health IT, and in this case, especially the alerts that accompany them, but also for medication safety, especially using a human-centered design to reduce that alert fatigue, improve clinical decision-making, ensure the right medication reaches the right patient at the right time. We're honored to have Dr. Prithima Mosaly with us today. Dr. Mosaly brings more than 12 years of experience in patient safety and health information technology, specializing in simulation-based training, continuous quality improvement, electronic checklists, and data analytics. As part of the Ben Reddy consulting team and a partner of ours here at Sinensis, she has supported major safety engineering and human systems integration initiatives across the VA health system, collaborating closely with the VA Informatics Patient Safety Team and the VA National Patient Safety Center. Dr. Mosaly also has served as adjunct faculty at the University of North Carolina, Go Tar Heels, undergrad alumni, where she developed and delivered courses on human factors, systems engineering, and safety analysis. Her earlier work includes establishing and leading human factors lab focused on improving provider interaction with electronic health record systems. She's published extensively, and I encourage you to see some of her journal articles, and they are fantastic, and remains an active member of the Human Factors and Ergonomics Society, which is going to be presenting at the annual meeting in a couple of weeks. I've personally learned a lot already from the time that I've spent with Prithima, and I know you all will too. A quick reminder, today's session is being recorded, and you could submit questions and comments anytime through the Q&A feature. The chat will actually be disabled during the presentation, but we'll open it back up at the end of the presentation. But feel free as we go along to put comments and Q&A in the Q&A section. With that, let me turn it over to Dr. Mosaly. Over to you, Prithima.
Well, thank you, Steve, and thank you, Riley, for the great introduction. And I'm honored to be here. I'm grateful for the opportunity to participate in the Patient Safety Awareness Week webinar series. Yesterday, in this webinar series, we have the privilege of hearing from Dr. Richard Greenhill on quality and AI. So building on this framework of AI as a powerful yet fragile layer within our patient safety ecosystem, where challenges such as data quality, governance, and alert fatigue can directly translate into patient harm, my talk today focuses on a very concrete example of these risks. So today, I will focus on barcode medication administration alerts at the bedside and describe how a human-centered design approach was used to evaluate and redesign BCMA alert messages. So the goal of this work is to reduce the alert fatigue, support clinicians' judgment, especially nurses' judgment, and ensure that safety alerts actually align with real clinical workflows and patient safety needs. With that, I'll get started here. So medication administration relies heavily on BCMA alerts to prevent medication errors. So these alerts act as a safety barrier or safety net that helps nurses verify medication orders during administration. However, usability issues in the wording of alerts can prevent nurses from correctly identifying three important things. First, why an alert occurred. Second, what action should be taken. And third, what safety risks is involved or risks are involved. So when alert does not communicate these elements clearly, they create a hidden patient safety risks. So let's imagine a nurse administering medications during a busy shift, and the patient wristband is scanned and an alert appears. So this message may be vague and the button may not clearly indicate what action should be taken. So at that moment, if the nurse must decide whether to stop and troubleshoot or dismiss the alert and continue. So in that moment, the design of alerts itself become part of the patient's safety decision. So this project started by examining whether BCMA alerts truly function as patient safety tools or whether usability issues are introducing cognitive friction during medication administration. So why this matters? Poorly designed alerts can contribute to several types of medication safety risks. These include wrong patient errors or wrong form of medication administration, wrong dose administration, wrong route, and even medication administered at the wrong time. So these are exactly the type of errors that BCMA systems are intended to prevent. BCMA alerts exist to protect patients. However, they can only fulfill that function if nurses can quickly understand them during a busy clinical workflow. And human factors research shows that alerts must support several safety functions. They must help nurses detect that something is wrong, identify what went wrong, correct the problem, and then resume the workflow safely. If an alert detects a problem but does not clearly guide the nurse towards a resolution, then the safety functions or the function of the alert is weakened. So from a patient safety perspective, alerts should function like a clinical co-pilot, helping nurses interpret and respond to safety issues rather than simply displaying systems warnings. So human-centered design, as described by International Organization for Standards, is an approach that focuses on designing systems around the needs of users and their work environment. In healthcare systems like BCMA, human-centered design ensures that technology supports clinical decision-making, safe workflow execution, and rapid error detection and correction. Human-centered design follows an iterative cycle rather than a single linear process. So as you see on this slide, the first step is the analysis phase, which is understanding the context of use, mainly who the users are, what tasks they perform, and the environment in which they work. Next, the requirements are specified based on what the system must accomplish to support those users. Then comes the design phase. Then we design based on the user needs and requirements. We design solutions in phase 2, and this kind of feeds into could be one design or more than one design as prototypes. Finally, those design solutions are then evaluated with real users through usability testing and other human factors methods. And remember, these phases are iterative. And as you see on this slide, it is cyclical. So anything that doesn't match, then we go back all the way to phase 1, which is understanding user needs. So an important concept here is the difference between work as imagined and work as done. So taking a human-centered design approach, we can clearly understand the difference between the work as imagined and work as done. Usually, systems are often designed based on how designers and other stakeholders believe work should occur. That's work as imagined. However, clinicians and nurses operate in real clinical environment that involves interruptions, multitasking, and time pressure, constantly adapting to the situations to provide the quality of care to the patient. That is how the work is actually done. So human-centered design helps ensure that systems align with how work actually happens in clinical practice. So Woods and Murphy published guidelines on how error messages and safety alerts should function based on human factors principles. Alerts should not simply warn users that something has gone wrong, but should help clinicians diagnose and resolve the issues. So these are the 7 principles that they published. The ideal state is to eliminate or prevent errors from happening. But if it is not possible, then efforts should be made to reduce the occurrence of those errors. And when errors do occur, help the user detect the errors quickly and help them identify what occurred and why. Then lead the user to options what will correct and help resume the work quickly as possible. For BCMA alerts, this means the message should clearly communicate what triggered the alert, what the clinical risks may be, and what actions the clinician or the nurses should take next. Our earlier work on the BCMA alerts showed that many alerts were able to detect a mismatch or safety issues, but they did not clearly identify the cause or the appropriate correction. So when alerts lack this information, nurses may need to interpret the system messages on their own while working under time pressure. So this increases cognitive workload and can contribute to alerts being dismissed prematurely. So these findings became the foundation for the alert wording redesign that was evaluated in this project. So we started by convening a multidisciplinary stakeholder group, which is the phase 1 of human-centered design approach. That included our nurses and nurse informaticists, pharmacists, human factors engineers, and EHR specialists. The first step was creating an inventory of BCMA alert or alert messages across the medication administration workflows. For that list, the group discussed several important factors. First, was there any clinical risk or potential for clinical risk was the first discussion point. Then some alerts directly relate to critical medication safety events such as wrong patient identification, incorrect medication dose, medication given outside the scheduled time, pharmacy verification issues. These all list of alerts align with the fundamental medication safety principles of the 5 rights of medication administration. Next, we looked at how frequently alerts occurred during real clinical workflows. So we looked at the data. We looked at the data that for high frequency, especially for high frequency alerts that appear frequently have a larger impact on clinical or clinician workload and decision making. Third, we discussed override behavior. Like when alerts appear too often or are poorly understood, nurses may override or dismiss them quickly. This increases the risk that a true safety issue might be ignored. Fourth, we evaluated reported confusion among nurses. This was gathered on the floor. Some alerts used terminology that was unclear or inconsistent with clinical language. Finally, we assess the overall impact on medication administration workflows. So in phase 2 of the human-centered design approach, which is to design and evaluate alerts, usability testing methods commonly used in human factors engineering were applied. So we created mock-ups of BCMA alerts and embedded within simulated clinical scenarios. The participants were asked to perform medication administration tasks while encountering these alerts. Our study used a think aloud protocol, meaning participants were asked to verbalize their thought process as they interpreted alerts and decided what actions to take. This allowed our team to understand how participants interpreted the alert language and whether the message supported correct decision making. We had 6 nurses participated in the study. 4 were experienced users and 2 were novice users. And we had participants from both Veterans Health Administration and Defense Health Agency. Our sessions were conducted remotely through Microsoft Teams, and each session lasted for approximately 60 minutes. So our results in a high level, at a high level, most alerts were successful in detecting safety issues, such as mismatch between medication and orders. However, many alerts did not clearly support resolution of the issues. Ambiguous wording increased cognitive workload because nurses had to interpret the meaning of the alert rather than receiving clear guidance. And in some cases, button labels and message structure created confusion about which action should be taken. Frequent alerts also raise concerns about alert fatigue, particularly when alerts appeared often but did not provide clear information. One important finding was that relatively small wording changes significantly improved clarity and interpretation for the nurses. So this suggests that alert messages should function as clinical guidance tool, not just the warning message. So getting into the details of our results here, understanding the difference between work as imagined and work as done is a key concept in human factors engineering. The BCMA system, in the BCMA system, the medication administration is typically imagined as a linear process, which mainly consists of scanning the patient, scanning the medication, reviewing any alerts, administering the medication, and documenting the administration. However, the real clinical workflow, which is work as done, is more dynamic. So work as done reflects how nurses actually perform their work in practice, meaning nurses may scan multiple medications before administration. Alerts may appear at different stages in the workflow, and nurses may need to adapt workflow when scanning fails. So interruptions, multitasking, and differences in clinical settings also influence how medication administration occurs. So when alerts are designed only for the ideal workflows rather than real workflows, nurses may struggle to interpret them quickly or may even bypass them. So because BCMA alerts are one of the final safety checks before medication administration, aligning alert design with real clinical workflows is critical for patient safety. So this is a very high level of our work as done mapping. So unlike the idealized workflow, the real workflow is often cyclical rather than strictly sequential. And nurses adapt to alternate methods when scanning fails in any of these steps within the process. Here are some of the examples of messages that we used for the study and how we used an iterative human-centered design process to come to a close to an optimal language for the warning messages. This slide shows a wrong patient alert. As you see on the slide, this is the actual warning message that occurs when scanning patient identifier when it doesn't match the patient record currently open in the system. So from a safety perspective and evaluation based on the design guidelines, this alert successfully detects a potential safety identification issue, but this alert may cause the user to halt medication administration, check the patient identity. That's great, but it does not indicate what does not match, whether that's FIN number or the MRN number. It doesn't give a clear indication of where the mismatch is. An alert does not suggest methods to solve the issue either. So the resolution is to add complete sentences in our first iteration for better readability and add more guidance on next steps to reduce ambiguity. So we incorporated those initial set of suggestions. We modified the alert or the alert language after discussing with the nursing and informatics stakeholders and the EHR developers. Then we took it to our real users for evaluation. We found that the alert did clearly identify what information did not match or how the nurses should resolve the issue, but some participants also noted that the wording used could be interpreted in multiple ways. For example, the phrase patient label could be associated with medication or laboratory labels rather than the patient identification numbers. So participants also said that this alert is rarely encountered. So we incorporated those feedback into our final language change on this slide. The recommendation redesign focused on improving clarity by, as you see on the slide, mainly using complete sentences, clarifying terminology, and providing clearer guidance on the next steps for verification. So these changes help ensure nurses can quickly verify patient identity and resolve the issues safely. However, as the nurses indicated, this warning message is not frequently encountered. Then we looked at something that were more frequently encountered. So our second example here is related to dose mismatch. This alert appears when the system detects that the scanned medication dose does not match the ordered dose. So based on our guidelines and the design principles, the alert successfully detects the discrepancy, but it failed to provide suggestions for methods to solve the issue, and it does not provide users with additional information for mitigation. So in this case, the concern could be that the nurse may not administer medication or may continue with wrong dose based on incomplete information. So during our first set of modifications, we changed the alert message during the brainstorming sessions with clinicians and our stakeholders. Then we conducted the usability evaluation with the actual users. In this iteration, we provided suggestions to resolve the issue and mitigate, as you see on this particular alert message on the slide. Participants reported that the wording was something difficult to interpret quickly. Additionally, the arrangement of yes and no buttons created confusion. For example, selecting no was required to scan additional tablets or doses, but user might instinctively select yes and move forward incorrectly. So great feedback. The message was also considered too wordy by some participants. And also note that participants, as they commented, that they encountered this message very commonly during the administration process. So we gathered all the feedback, then we implemented our second set of improvement, or the design prototype for improvement. The redesign recommendations included reduce the number of wordings and clarify the wordings for clear interpretation, repeating the underdose warning in the body of the message, and clarify which action should be taken depending on the user's choice. So these changes improve the ability of the alert to guide nurses towards the correct resolution. And we did the same thing for overdose. Underdose and overdose were the two messages that were frequently encountered, especially for the inpatients at the bedside. So we took a similar approach to modify the overdose warning messages. And in the interest of time, I'm going to skip this example. But in conclusion, this work highlights an important point about patient safety. That is, technology does not improve safety simply by being present. So safety emerges when technology supports human decision-making and clinical workflows. BCMA alerts represents one of the final safety nets before medication administration. So improving the clarity of these alerts helps nurses interpret them quickly and make safe decisions. And human-centered design helps transform alerts from generic system warnings into more actionable clinical guidance. We do recognize the limitation of this study, and this study includes feedback from only 6 participants. What this sample size is typically is very typical for usability testing. Additional testings with more participants could provide more further insights and further enhancements. Future evaluations could also explore how alerts are interpreted across different clinical environments and also at different levels of user experience. So in continuation for future direction, this research may include evaluating alert override behavior and examining the relationship between alert frequency and potential patient harm. Additional research could also explore the design changes that modify the underlying interaction logic of alerts such as implementing forcing functions that prevent safe actions. These approaches could further strengthen the role of BCMA alerts and safety nets during medication administration. But in summary, alert design should be viewed as a patient safety intervention. Human-centered design, again, improves alert clarity and support clinical decision-making. Clear alerts strengthen medication safety systems for sure. But before closing, I want to briefly connect this BCMA work to the broader discussion on AI, quality, and patient safety. The BCMA alert redesign illustrates an important principle, which is technology improves safety only when it supports human understanding and decision making. So as healthcare increasingly adopts AI, the same principle becomes even more important. AI systems may detect patterns in data or even generate predictions, but those insights still need to be interpreted and acted upon by clinicians. Human-centered design plays a very critical role here. The same HCD approach used to improve BCMA alerts can also guide how AI systems are designed, mainly ensuring that AI outputs are transparent, interpretable, and aligned with real clinical workflows. So without this, issues such as data bias, model degradation, or unclear recommendations that were all discussed yesterday can introduce new safety risks. But when AI is designed using a human-centered principles, it can augment clinical decision-making, highlight any potential risks earlier in the process, and also strengthen patient safety systems. So whether we are designing medication safety alerts or AI decision support tools, the goal is the same: to build technology that supports clinicians in making safer decisions for patients. So with that, I conclude the presentation and I'm happy to take any questions.
Wow, that was great, Prithima. What a great presentation. Thank you for that that knowledge, sharing your knowledge with us and the experience as well. I would just direct everyone. I kind of threw the first question in there as I was listening into the chat, but feel free to use the Q&A feature. I think the chat is open as well, so we'll be looking at both areas. But I'll start with the first one. Prithima, on the, are there best practices for safely managing alerts within a system over time? So how does a facility, someone who's in the patient safety world there, thinking about their health IT systems, and there's so many of them. You just mentioned the BCMA alerts, but there are other clinical decision support alerting that's going on. How do you, what are some best practices, or did you look at that in your work about how these alerts, once they get set, it's almost like we set it and forget it kind of thing. So any thoughts on that as you were doing this work about how you could go back and sort of, maybe audit or look at these alerts and see if they're even relevant or they're actually achieving the results that you want them to achieve, just from a proactive standpoint? Any thoughts there?
Sure. Great question, Steve. In fact, that's what we emphasize on, is always understand work as done. So when these alerts regard, in whatever context, whether that's in BCMA or maybe in other aspects, whether that's risk prediction or flow sheets, reminders, all applies to the patient safety, potential patient safety risks. So understanding the work as done and some of the pain points that the end users are experiencing are very critical, and that should be captured. And again, associating those pain points with the historic data always gives a very quantitative view of what needs to be done and how to prioritize where the system gaps are. So of course, yes, understanding these, understanding the user needs, understanding the workflows, work as done, I think provides or informs a critical step towards taking those improvements, whether you're making the language changes to the alert messages, or even understanding whether that alert is required in the first place to be triggered at any given point. So assessing the effectiveness of those alerts also becomes critical.
Yeah, I would imagine a little bit like yesterday and some of your last comments around the kind of working with your vendors, how you're going to actually change these alerts is important, and thinking about ways to make them work better for the clinicians. That's really important. I think one of the things that got me also another insight that I brought in was the idea that this is so impactful because oftentimes we get an event reported one instance at a time, right? That a medication error occurred, and I know the data is pretty strong on medication errors that 15% of people who enter a hospital setting will suffer a medication error. That's a pretty staggering number, really, when you think about how many patients would experience a medication error, and I think everybody wants to make sure that we avoid those, and I could see that these are unintended consequences, but oftentimes we just blame the person who made the error, and I think what you saw here, even from the small size n, is that this is what you solved is a common problem for users at the user side, but that it ripples and it has a huge impact on the number of orders that are placed, right? So you're making, I mean, this just, I could really kind of feel the system perspective of this, of how you could avoid errors. So I guess it was more just an insight as well from that perspective. And then I think another piece too was the idea that the linear versus circle. Can you elaborate a little bit more on that and thinking around your processes? Because I think oftentimes we see process maps developed as linear rather than when we're thinking through how something either should happen or has happened or does happen. Do you want to kind of help us with a little bit of that circular and kind of more reinforcing loops or some other ways of thinking this than linear?
Absolutely. And when I talk about work as done, understanding work as done and understanding user needs, those are some of the loops that we get to understand, even to get some awareness of why the loops are occurring in the first place. And number two, the frontline workers are the ones that have the best solutions. They know when things doesn't work, they have adapted to alternate workflows. The critical point is providing the timely patient care to the patient in the right form, in the right time, whatever the 5 rights are. But in that case, I think when things don't work according to their expectations, there are some solutions that they have developed. It could be just writing on a piece of paper, although it's not a safe process or a safe process step within the entire process. But I think that's another solution. If they're writing it, we need to understand that there should be some alternatives that should be provided. It cannot be a rigid system. It has to have some variability, but again, designing that guardrails of wiggling through that safe variable work performance. I think that's what we try to do when we talk about proactive safety. It's like, concrete, making the standardized process would not work. We all know that standardization would not work in healthcare. So I think understanding that level of variability and what other solutions or alternatives could be provided to the healthcare workers, I think would be a great solution. And I see one of the questions here in the chat is, thoughts on AI having to replace it in terms of alerts correctly. Absolutely. Alerts can take up most of these, I would say, low-hanging fruit. AI is great technology as long as human is in the loop, and human is the final decision maker. AI can augment the decision making, but when human is given the authority to make the final decision, I think many such solutions, alternate solutions, can be incorporated within the work as done or within the safe variability for the process to generate this safe patient outcomes.
Yeah, I think the other comment that you made, I kind of highlighted it too, was the fact that you have a health IT system present, right? Like BCMA or other things that we're becoming more familiar with, and then other clinical decision support systems and ways to help that. Just being present doesn't, in fact, make the system safer. I thought that was a really important kind of instance because I think again, like we talked about, um, an assumption, right, that if you have this technology, it's safe. And so I also or safer, because we got that a lot with barcoding, right? Like this was really gonna, I think initially CPOE was another intervention. And so I think that's really kind of that healthy skepticism that you're bringing to our systems that we'll have to bring forward in thinking about, for instance, the fact that the way you talked about the five rights, and thinking about those, that here interruptions might just be in the fact that you might be making a med draw, and kind of those types of errors that we would say that an interruption we might be able to try to prevent. But when you mention this, that interruptions were a part of the work as done, that were involved in use of the actual BCMA process, right, and the alerts that are associated with those. So I just think that both of those are really important because I think we feel like we moved to some sort of automation or electronic system, and that we remove some of those hazards and risks that you talk about. So I thought that was really helpful. Let's see if we got some other ones in here. In a BCMA project, was the human factors team integrated with the BCMA team, or were you working independently? And then were they receptive to integrating the human centered design process?
Oh yeah, absolutely. The BCMA work was integrated into the human system integration team's work. And we collaborated with leadership, including the federal EHR system developers on the team. That was a great advantage that we had for the BCMA project, because they knew the system technical limitations. So when we proposed to change the buttons, from OK to yes, no, and what yes, if somebody presses yes, what is the logic behind it? I think understanding those limitations made us to think out of the box, like what alternate solutions that we can develop if the technology is a limitation. But having said that, when we talk about patient safety, especially when we talk about proactive safety, we also discuss about the centralized approach and a decentralized approach. So having those guidelines and standards are helpful to a certain extent, but when we think about having these technologies used in various contexts and various environments, those standardizations might not work. So that's the decentralized approach. So what can we create? That's a variability that we can incorporate into the standardized approach, having those guardrails built into the standardized approach so that safe level of variability can be really encouraged. And also implementing those kind of safe variability approaches will give multiple solutions, which can sometimes overcome some technological limitations, but also leading the way of where AI can really be helpful in minimizing the repetition, the monotonous work, that can relieve the frontline nurses or the frontline clinicians from repetitive work to more patient-centered care or providing more patient-centered care. And I'm just piggybacking on what you mentioned, but great discussion.
All right, I'm going to give you a scenario here. Just thinking through this, I'm a patient safety professional out there, or patient safety officer. I'm getting a report, patient safety report, and what are some ways that what are some of the key things I should be looking for in that report that might trigger that this might be a human-centered design challenge? I mean, do you have any thoughts on that about that report that would sort of tip me to sort of think human-centered design here?
Absolutely. I myself have served as a patient safety associate at Duke University. So we used to review these reports, whether there was a good catches or patient safety events or even near misses. We would have a standard approach of how to look at the entire event or a near miss. So we tend to blame the frontline clinician, who unfortunately was present during the event when the event has happened. But we always try to get away from blaming the folks or blaming the people in the front line. So we take a more standard approach. There are many root cause analysis methods that are out there, but we particularly follow the HFACS model, which is human factors assessment for safety events. And that has been validated in other domains like aviation and nuclear power plants, which mainly helps us to identify what type of error was that. Was that a mistake or a rule-based error or or a slip? Then we take that to another step back, saying that what was the precondition before this error happened? Was that nurse working overshift? Was the technology working at that time? What was the lighting level? These are all the preconditions that might have resulted into this particular event. So think about Swiss cheese. I know Swiss cheese is very linear, but when you start putting the human HFACS model on Swiss cheese and then understanding the difference between work as done, work as prescribed, so putting all these different methods together will clear out the picture in terms of what the root cause was, which led to an event that you're reviewing. It's what were the previous history of similar events. So data, looking at the historical data, will also provide great insights. I think it's not one event that we analyze, but looking at the historical similar events and then putting them together will give a broader picture in terms of various themes that might have resulted in similar events. So I would take that, and with these different themes, there might be one or many solutions for each theme. It could be a policy change. It could be maybe some kind of an IT technology change, or it could be even introducing AI. All these could be solutions that might come up. But again, not stopping just finding the potential solutions, but mocking those solutions up, then testing it in a very small scale, piloting it to make sure that that is what will really address the pressing issues. And that is what will seamlessly be fit into the clinician's workflow, has to be validated before rolling out or implementing these solutions.
Yeah, awesome. Wow, that's very practical. Very practical. I know a lot of the professionals that are probably on this call are familiar with HVACs. So I think that was a really good way to think about how they could incorporate thinking about human-centered design within their HVACs analysis, right? As they go through this. So, well, I know we're at time, so I want to be respectful of that. I just want to thank Dr. Mosaly for her time and her sharing of her experience and answering some of our questions today. It's really, really been helpful and sort of building on the webinar series